Hello, my name is Peter Sambarlis. I'm an assistant professor of urology at Northwestern Medicine, and today I wanted to go over an interesting case of testicular pain. The gentleman that we were treating is a 41-year-old male who had been dealing with multiple years of low-grade, achy, chronic testicular pain that waxed and waned. He had already received a lot of urologic care and some excellent care, which ultimately did not relieve his symptoms. He started with pelvic floor physical therapy, which is an excellent therapy with a very high efficacy rate. However, it only lowered his pain from a level of approximately 4 out of 10 down to 2 or 3 out of 10. And with his goal of complete resolution of his pain, he presented to explore more options. He also tried medical therapy, and there's some excellent research suggesting that a combination of certain medications like tamsulosin, which is usually used for the prostate, and anti-inflammatories like ibuprofen or Tylenol can treat chronic pelvic pain. Unfortunately, this didn't work for him as well. He obtained an ultrasound, which was significant for bilateral varicoceles, dilated veins in the scrotum on both sides, and a little bit of complex fluid around the testicle. This complex fluid is relatively common, and it's hard to interpret what it means, but when we know that somebody is having testicular pain, we have to consider all of these slightly unusual findings as a possible culprit. Because he had tried so many effective therapies with a limited response, we thought he may have some nerve-based testicular discomfort. And for that reason, we performed a diagnostic cord block in the office. This is done with lidocaine or local anesthesia, meant to remove sensation from the testicle. We know that lidocaine lasts about 4 hours. So if the patient has a significant pain response, in other words, resolution of his pain for 4 hours or more, that predicts that he can do very well with a surgical intervention that we call microdenervation of the spermatic cord. We always do this twice because we cannot see pain. So in order to be confident in our operative success, we want to make sure that someone has a favorable response to a local anesthetic block at least twice in the office. That happened for this gentleman, so we did proceed with microdenervation of the spermatic cord. We make a small incision in the inguinal region and pull the spermatic cord up through this small incision. Then, using an operative microscope, find all of the nerves and cut them with electrocautery. We preserve all of the important tissues, in this case, the arteries and the vas deferens, so fertility is not compromised, and neither is the blood supply to the testicle or things like testosterone and sexual function. When the procedure is done, we close the skin incision and cover it with a Band-Aid approximately the size of a ravioli, and he was sent home the same day. This patient had an excellent response and reported complete resolution of his pain at the 2-week follow-up visit.